we're gonna just allow for a few more minutes for folks to join in. So once again, we'll be beginning our formal program at 12:05 Eastern Standard Time. Thanks. Hello, my name is Charles Wilson, and I supervise the Community Health Education Division at the Washtenaw County Health Department. I want to take this opportunity to thank everyone for tuning into today's webinar. I also want to introduce Gabrielle Burgess-Smith and Amanda Ng, the two health department staff who are the architects of this series. Gabrielle and Amanda are present on today's webinar and are working behind the scenes to ensure that everything goes smoothly. And finally, I'd like to introduce Gabrielle Slingcare from the Washtenaw County Medical Society. Gabrielle has partnered with us in creating these webinars, so a big shout out to her and the Medical Society for the important work that they're doing in our county. As a result of COVID-19, this series was transitioned from an in-person conference to a virtual one. Funding for this series is provided by the Marijuana Regulatory Agency of the Department of Licensing and Regulatory Affairs. I wanted to let everyone know of the various locations of the information, tools, and other useful tips that will be shared during today's webinar. This webinar is being shared via Facebook Live and is being recorded. The recording will be available on our Facebook site for later viewing. The slides shared by today's speaker will be posted on our website at washtenaw.org/marijuana and on social media at WC Public Health. These website locations will be placed in the chat box as well. And speaking of the chat box, please feel free to post questions in the chat at any time during this webinar. At the end of the presentation, we'll be answering questions. And that concludes the housekeeping portion of today's program. At this time, I'm going to turn it over to Gabrielle from the Medical Society to introduce our speaker, Dr. Laura Borgelt.
Thanks, Charles. Hi, my name is Gabrielle Slingcare, and I am the Executive Director of the Washtenaw County Medical Society. I have the pleasure of introducing today's speaker. Dr. Laura Borgelt is an Associate Dean of Administration and Operations at the University of Colorado Skaggs School of Pharmacy and Professor in the Departments of Clinical Pharmacy and Family Medicine at the University of Colorado Anschutz Medical Campus. Dr. Borgelt's teaching, practice, and research focuses on patient safety and women's health. Welcome, Dr. Borgelt.
Thank you so much, Gabrielle, and thank you, Charles. I really appreciate the introduction. I'm going to go ahead and share my screen, and welcome to all of you. Hopefully you're seeing this, and I'm going to put it into slideshow mode. As Gabrielle mentioned, my name is Laura. I'm a professor and associate dean here at the Skaggs School of Pharmacy in Colorado. And for today's presentation, I don't have any relevant financial disclosures. Of course, we'll be talking about cannabis, which is unapproved federally. And I've also worked closely with our public health department in a variety of different contexts, some of it with research and some of it also as a member of 8 different working groups, primarily with the lens of patient safety. But of course, we've done quite a bit of work in Colorado as well with regard to medical uses of cannabis as well. So I look forward to presenting to this group in particular because with the health department and its important impact to our patients and to our community and to our providers, I really appreciate all the work that goes into trying to create good, clear, concise, and helpful information for our stakeholders. I just want to tell you a little bit about my story. It was not my intention to become an expert in cannabis. I have worked over 20 years in family medicine, and really my role there in this clinic, or in our family medicine clinic, is to help our providers be better prescribers. And in this context, I do a lot of teaching with our residents, physicians, PAs, nurses. We have psychologists in our clinic. It's very interprofessional. And this is our precepting room. So you can see me there on the left, working with, in this case, a medical resident, a psychologist, and a PA. And one day in our clinic here in this precepting room, a resident came into the room to talk about the patient that she was seeing. And in this case, it was a breastfeeding mom who was smoking a joint per day. Now, the resident wasn't really coming in to ask about that. She actually had told the patient that that was completely fine to be smoking a joint per day while breastfeeding. And I sat there in my chair thinking to myself, you know, I'm pretty sure that's wrong, but I don't know if it's right. And it was really this uncertainty and the question about what cannabis was as a drug, how it might be working in this context in lactation, certainly in pregnancy and other vulnerable populations I know you've already had some presentations in adolescents. The elderly would also be an example of a vulnerable population. And so really having that context is important to understand that in this context, there's a vulnerable population at stake. And, you know, this really led me to look at some information. I reported what little information was available to the team at this time. And, you know, essentially what ended up happening was the physician in the room made a recommendation for me to give a talk at our Colorado Medical Society, and I became an expert in cannabis. And that really wasn't my intention. However, my areas of passion in women's health and patient safety were all of a sudden coming together in one place. And I felt like it was really important with knowledge as a pharmacist to talk about how cannabis could be impacting our patients as a drug. And like any other drug, I've come to learn that cannabis has potential benefits and potential risks. And it's all about the weight of that benefit risk analysis in the patient that's in front of you. And so today, what we're really focusing on is the pregnant and lactating population. Just know that if I were to give a talk on migraine or maybe pain and oncology, for example, the talk could be very different. For today's presentation, I'll be talking about the use of cannabis on the endocannabinoid system and the fetal development, reviewing studies that have evaluated the use of cannabis in pregnancy and lactation, and then really hopefully sharing some resources with you about how we can better counsel patients and some of the challenges we face regarding women using cannabis when they are pregnant or breastfeeding. So this was one of the first pregnant patients I had come into clinic shortly actually after the breastfeeding patient I just told you about. This is a 27-year-old female. She came into clinic for her second trimester prenatal visit, 24 weeks, was taking a prenatal vitamin, was not drinking, not smoking tobacco, but was smoking cannabis 1 to 2 times a day. And initially she was using it to help relieve her nausea in that first trimester, but has continued it because it was really helping her sleep better. She had heard about cannabis having potential harm on the fetus, but really didn't feel the studies were done well enough to make conclusions about the harm, and really felt that for her, the benefits were outweighing the risks. And so the question here, the first question that we can ask is, you know, what effect could cannabis have on this patient and the fetus? So what we're going to be doing now is just discussing the role of cannabis on the endocannabinoid system during fetal development. So by now, if you've attended the other presentations, I'm sure you're familiar with the endogenous endocannabinoid system and all that comes with it. And understanding that this system is really trying to stay in balance and will produce endocannabinoids on demand when needed to make sure that regulation stays intact and in place, and is interacting very closely with the CNS and other systems in the body. So we have these endocannabinoids throughout the entire body. We know that the goal of the endocannabinoid system is homeostasis, or maintaining balance. We know that there are a lot of receptors in the endocannabinoid system. The two that we know the most about are CB1 receptors and CB2 receptors, with CB1 receptors being really prominent in the brain, throughout the nervous system, and CB2 receptors being very prominent in the immune system, in the gut, and in other places in the peripheral structures as well. And of course, then that leads us to talk about the actual endocannabinoids. There are a lot of endocannabinoids. The two that we know the most about are anandamide and 2-AG. Again, keeping in mind that anandamide is that bliss molecule that helps us kind of feel good, I suppose you could say, after a marathon, for example. We talk about endorphins often being the thing that the chemical that's circulating, but it's actually anandamide, and that anandamide really helps in many times when we are experiencing challenges like pain or exhaustion. And so these endocannabinoids can really help regulate some of these systems and help us to feel better, help us feel good. Now, just a little bit here as a reminder, perhaps, is that anandamide and THC look very much alike in their chemical structure. So when anandamide is binding to a CB1 or CB2 receptor, body recognizes it as an andamide and can create an appropriate response. When THC binds to that CB1 or CB2 receptor, it also recognizes it, but this time THC is hundreds to thousands times more potent. So rather than having a bliss molecule, when THC binds to those receptors, it creates a significant high. And people will experience that psychoactivity, maybe even psychotoxicity, depending upon how much they've consumed. And so that THC, really increases the response on that receptor. Now, what that means, for us, when we talk about cannabis as a plant, is that there are a lot of different cannabinoids in these plants. THC, CBD, CBN, CBC, CBG. I mean, the list goes on and on and on. Now, this is a good point for me just to mention, and you may have talked about this in your prior webinars, but there are FDA-approved medicines that are synthetic derivatives of THC. These examples of that would be Marinol or Dronabinol and Nabilone. We also have currently an FDA-approved CBD product, which is actually derived from the whole plant. That is Epidiolex or cannabidiol. The product that's on the, approved in about 25 or 27 other countries in stage 3 trials right now, phase 3 trials, is called Sativex, which is a 1-to-1 mixture of THC and CBD, and that is a blend, an equal blend of the THC and CBD from the whole plant. And that's primarily used for muscle spasms in multiple sclerosis. So I say all that because it's important for us to understand that cannabis as a medicine has been used for many years, thousands really, since about 3000 BC. But we do have FDA products, but what we're really talking about today is the cannabis plant that is, been approved in the medical and recreational contexts in Michigan and in other states like Colorado, for example. Now, in this plant, we also have terpenes and terpenoids, which is the smell that's generated from the plant. And because it's a plant, there's also flavonoids, sterols, thiols, phenols. Now, one thing about cannabis that's important to note is that it is very lipophilic. There are lipids and waxes in the plant, but because it is very lipophilic, that means it enters into the brain easily and readily. It also crosses the placenta readily and easily, and it goes into the breast milk readily and easily because of that lipophilic nature. And so those are key places for us to keep in mind that cannabis can have impact. Of course, cannabis is also a fibrous material. Hemp has been used in bags and ropes and clothes and many different materials. So cannabis is really, as much as I want to say it's just a weed, it's actually a very complex plant. And for the most part, where we derive our data is from smoked THC. And this is something to highlight because especially when we're talking about the pregnant and lactating population, I'll mention it a little bit, but we just don't have a lot of data around CBD, even though I know CBD has become more and more and more popular. It's readily available online and in grocery stores and all of these gas stations. We have to be cognizant of the data and the information primarily coming from the THC literature and not other cannabinoids. So when we look at the endocannabinoid system, it's important to note that its development is occurring at 14 to 19 weeks gestation. So this is early in the pregnancy cycle. This system is developing to integrate all of the endocannabinoids and the receptors and create these appropriate responses. And so when we have a product like THC that's hundreds to thousands times more potent, there can be a really dramatic effect that could occur in the system. So I'm going to tell you a little bit more about that. When we look at the fetal endocannabinoid system, we actually find that there's a higher level of CB1 receptors in the fetal brain compared with the adult brain. Of course, making it more susceptible to potential endocannabinoid or exogenous cannabinoid targets. And we know that with this higher level of CB1 receptors, it's playing a very specific role for key developmental events in the endocannabinoid system, things like metabolic support, cell proliferation and migration, even neuroprotection for the CNS. And I will just say that's just an aside, but is a reason why there's so much interest in things like TBI or in these football injuries that we're seeing in the press. It's also key for axonal elongation, synaptogenesis, and neurotransmitters. And so what this is doing is really helping our nervous system communicate and respond appropriately for neurotransmitters to be released when they should, where they should, and how much they should. And so by having this synaptogenesis and neurotransmitter production within this context of the endocannabinoid system, it's really important for key developmental events. Now, we know that when cannabis is used during pregnancy, there is a potential for supraphysiologic stimulation of this endogenous system. It can disrupt endocannabinoid signaling. It can interfere with synaptogenesis so that the formation of the synapses in the CNS may not connect in the same way that was intended. There can be interference with the development of neuronal interconnections. So axon development and growth can be impaired. And this is where it really becomes important because it's actually then disrupting entire neurotransmitter systems. In particular, we know that it can disrupt tyrosine hydroxylase activity, which is the rate-limiting enzyme for dopamine synthesis. Dopamine is really important in our reward pathways. Dopamine is also really important for full development of our brain. Now, I know you talked about adolescence in an earlier presentation. Keep in mind that the prefrontal cortex is one of the very last parts of the brain to develop. And because of that, when there's cannabis exposure during pregnancy, we may not see some of these neurotransmitter dysregulations occurring until adolescence. And that's one of the kind of the good news, bad news parts of this story, because some of the things that we see could happen more short term, but there are also signals right now that tell us that there are things happening longer term when cannabis exposure occurs during pregnancy. It can also alter other receptors, such as the opioid and serotonin receptors, other neurotransmitter receptors, but that's mostly been shown thus far in animal models. Now, I mentioned earlier, what about CBD in pregnancy? We really don't have comprehensive research at this time studying the effects of CBD alone on the developing fetus, pregnant mother, or breastfed baby. We know that high doses of CBD in pregnant animals has caused problems with the reproductive system of developing male fetuses. We're not exactly sure why. It may have to do with some of this homeostasis mechanism that's occurring, but we don't know for sure. There's a potential for CBD products to be contaminated with substances that can pose a risk to the fetus or breastfed baby, including THC. So what we're finding is that for some of these products, THC may actually be in a CBD labeled product. Now, of course, there can also be other contaminants like metals, for example, fungus, bacteria, other things that, because it's a plant, can impact a product's purity. And so, especially for the online products, it's much more risky when we look at potential contamination. And then based on the FDA approved product, we know that there are known risks for things like liver toxicity, sleepiness and fatigue, and drug interactions. So in summary for this part of the presentation, what I would say is that there could be an effect on this patient and the fetus with cannabis exposure. We know that cannabis contains nearly 500 chemicals, including THC and other cannabinoids. We know that exogenous THC has the potential to impact the development of the system. These effects may not be seen until adolescence. And like I mentioned earlier, we know that THC can pass through the placenta during pregnancy and through the breast milk during lactation. So now that we have some information about the pharmacology side, let's now move into the studies and what evidence that we have. And of course, I only can give you a sampling with the time that we have. I'm going to do my best to move through these, but just know that there actually is quite a bit of evidence out there in this population. This first meta-analyses Tori Metz and I took two articles that had been published and kind of compared them side by side. So in the Gun meta-analysis, it was 24 articles. In the Connor meta-analysis, it was 31 studies. In the Gun article, it was maternal and neonatal outcomes. And for Connor, it was really just neonatal outcomes. Now, when you look at what was found here, you can see a trend going right, meaning an increased risk for a variety of different outcomes. These are primarily the neonatal outcomes that we're looking at here, although there was one study that looked at maternal anemia, and that was statistically significantly different in the cannabis population. But you can see here that there's kind of this trend towards a low birth weight, for example, small for gestational age. And these are findings that we will continue to see as clinically and statistically significant as we look at other studies. We also saw some differences in the gestational age at delivery. We saw some significant differences in birth weight. The neonatal length was decreased in one of the studies, but really was not considered to be statistically, or I should say clinically significant, and also a change in head circumference, but again, may not be clinically significant. In another study looking at the retrospective perspective, this was people who were 15 years and older who had self-reported cannabis exposure in pregnancy. What they did was take unmatched and matched cohorts. What that means is that in the unmatched cohort, it was all women, those that had used cannabis compared to those that didn't use cannabis. In the matched cohort, they really try to account for factors that may affect the outcomes, such as sociodemographic characteristics, for example, or concurrent alcohol use or concurrent tobacco use. And so when they match the cohorts, they try to look at the cannabis users versus non-cannabis users in a more matched fashion. The primary outcome here was preterm birth, and there were 10 secondary outcomes, including small for gestational age, placental abruption, transfer to the NICU, and 5-minute APGAR scores, which is a standard scoring system that kind of looks at the overall health of the baby when born. When we look at that primary outcome, you can see here that in the unmatched cohort, it was almost twice as likely for cannabis users to have a baby with preterm birth. In the matched cohort, it was about 1.5 times more likely. Both of these findings were statistically significant and point to a potential for preterm birth in a cannabis population. Now, there are some limitations, and there's going to be limitations to any study. First of all, we can see misclassifications with self-report. You're relying on someone many years later or months later to look at whether or not they use cannabis and how much they use. Urine toxicology screening was not available, so it's hard to confirm use. And of course, we don't have good information about the frequency, the trimester of use, the duration of use. And while the cohort was matched, residual confounding can occur. So there could be other unmeasured or unknown factors that might contribute. So for example, one example might be stress. If they don't look at stress and didn't match for that, maybe that's a problem causing a preterm birth. So there are things that can still be left that we are uncertain about. In this particular very large retrospective cohort study, this was actually a cohort of 12.5 million patients from the National Inpatient Sample Database. Mothers again reported cannabis dependence or abuse. And really what they were looking at here was the association between cannabis use and pregnancy and adverse maternal or neonatal outcomes. What I'm showing you here first are the maternal outcomes. And what you see across the graph there is those that did not use cannabis, those that did use cannabis, the crude odds ratio, and the adjusted odds ratio. Now, the crude odds ratio is the data as it stands. The adjusted odds ratio is really, again, accounting for these characteristics that may sway the data a little bit. So they adjust for the sociodemographic characteristics as well as the alcohol, tobacco, as many factors as they can. And so really it's that adjusted odds ratio that becomes a more accurate determination of the outcome. And what we actually find here, which is very interesting, is a decreased risk of preeclampsia and gestational diabetes. And I will tell you that that particular finding, or both of those findings, have actually been shown in other studies. I'm particularly intrigued by the decreased risk of gestational diabetes. We're not exactly sure why that happens, but again, I think this will be an area of further investigation. We do know that we're balancing that with an increased risk of things like placenta previa, PPROM, or premature rupture of the membranes, chorioamnionitis, which is an infection. And we also know that there is a likelihood for an increased length of stay at the hospital. And so all those outcomes then are weighed as a risk versus any other benefit. And then of course we go to the neonatal outcomes. And if we look at the adjusted odds ratio, we see here a significant increase in preterm birth, intrauterine growth restriction, and intrauterine fetal demise. Now, the good news is that there are no changes or differences in congenital malformation. So this is not a thalidomide tragedy. We don't have that going on. And I really feel like it's a good thing. We're not seeing that in any of the studies thus far in terms of any major congenital malformation. The limitations, again, of this study are the demographics of women reporting dependence or abuse, that those socioeconomic characteristics. And, these can be inherently associated with adverse outcomes, so they're potentially confounding. Again, we try to adjust for that with that adjusted odds ratio, but may or may not, all the factors may not be accounted for. We have self-report or recall bias. Again, because these were women reporting dependence or abuse, they were likely moderate to heavy users of cannabis and not occasional. And again, we only have short-term outcomes, so this doesn't tell us about the long-term impact. This was a study looking at biologic sampling, again, a retrospective study with younger women. They actually looked at marijuana detection on universal urine toxicology or self-report. And what that does is just help to confirm the use. It tells us maybe a little bit about the extent of use, but doesn't give us a lot of specifics. The primary outcome here was actually a composite of outcomes, meaning that they combine a series of outcomes together and create a composite outcome. So the other outcomes they combined were preterm birth, hypertensive disorders of pregnancy, stillbirth, and small for gestational age. And what we found in this study was a statistically significant difference between cannabis users and non-users for the composite outcome. Now, and we know that because the p-value was less than 0.05. If you look at the other outcomes, you don't see a statistically significant difference here for preterm birth. You also don't see a significant difference for hypertensive disorders or for stillbirth, but you do see a statistically significant difference for small for gestational age. And so when those are all combined to then give this composite outcome, my takeaway is that small for gestational age is really driving that composite outcome to be statistically significant. So my takeaway here is that the small for gestational age being, in this case, almost 10% difference between the groups is really the statistically and clinically significant factor here. And again, interestingly, just to drive home a point, when marijuana exposure was defined by self-report only and not by the urine toxicology screening, the association with these outcomes became non-significant. So it really changes the impact. And what it tells us is that in some of the other studies where self-report is being used, we may be underestimating the outcomes. And so it's just an important factor to keep in the back of your mind. Of course, we still can have residual confounding. Urine toxicology may identify a higher risk group of women with heavier or more prolonged exposure. Urine toxicology may not be sensitive enough to detect marijuana through passive or secondhand smoke. Certainly that's not what we were looking at mostly in this study, but I get a lot of questions about that. We don't have good data on secondhand smoke. we're unable to determine the quantity or timing of marijuana. And of course, it's still short-term outcomes. Now, there is a study that many of you may already be aware of called the ABCD study. It's the Adolescent Brain Cognitive Development Study. This is a national study occurring here in the US. Very large population. They're looking at a variety of different factors that may affect adolescent brain development: diet, nutrition, and exercise, but alcohol, cannabis use is one of them. And so far, they have published a couple studies looking at the cannabis use during pregnancy. And this first one looked at psychosis proneness. And I'll talk about that in just a second. So this was over 4,000 children. 201 had been exposed to cannabis prenatally. And what they found was that there was an association with prenatal exposure after maternal knowledge of pregnancy, with a small increase in psychosis proneness during middle school for the children that were exposed during pregnancy. Now, what this means is that these children, these adolescents, had symptoms and signs towards psychosis proneness. They had not yet been diagnosed with psychosis, but what we know from other literature is that kids, when and if they are using cannabis, can be predisposed to schizophrenia potentially earlier than they normally would have been if they hadn't used cannabis. And so this is kind of just a continuing story about the potential development of the brain and the potential for psychosis, all the way starting from pregnancy now into middle school, and potentially later on when a condition like schizophrenia could emerge in someone's late teens or early 20s. Again, here we have a small sample. There could be underreporting. We don't have good data about the exposure. It's unknown if proneness is going to convert to psychosis, and there can be potential confounders. The other study that's been published has to do with sleep outcomes. And so they looked at cannabis use and early child sleep outcomes. Here, about 12,000 children, and it focused mostly on daily cannabis use or twice or more daily cannabis use. And what we found here is a statistically significant difference. And if you look at the p-values there, for almost all sleep types of outcomes. So duration, latency, excessive somnolence, and the sleep summary score was found to be statistically significant for anyone, for any prenatal cannabis exposure. And so this we will continue to take a look at. We certainly know the endocannabinoid system is a player in our sleep. And so we will continue to watch this, but I think it's an interesting finding that hadn't yet been shown before. And again, we're looking at self-report. There could be error in sleep measures because it was based on parental report. And there's a time lapse clearly between when they were exposed to cannabis and the assessment now of these sleep characteristics. The other two limitations I would add to any of these studies is the cannabis concentration. It has dramatically increased over time. The average THC concentration in Colorado now is about 18%, much, much higher than cannabis of the 60s and 70s when it was 2%. We also have many more cannabis formulations. It's not just smoked, although most of our data come from smoked cannabis. We have edibles and tinctures and dabs and really potent forms, as well as the way that it's consumed. And so I think if there's any dose response potential, which I personally as a pharmacist think there is, I think as we get more and more data in more recent time, we're going to find that there could be a significant dose response, and that potentially could add additional concern to some of these outcomes. In breastfeeding, there's been very few studies. This was one that was actually conducted at our children's hospital, looking at 54 breast milk samples and a variety of concentrations of cannabinoids. Most women were consuming it by inhalation and had reported at least daily marijuana use. All cannabinoids were detected in the breast milk samples except CBN, and it may just be that CBN wasn't a significant component of the products they were using. I think the key message for this study was that we found THC detectable in almost 2/3 of the samples up to 6 days after the last reported use. What that tells us is that there is significant amounts of THC that can remain in the breast milk for long periods of time. It's not really a pump and dump scenario like we have for alcohol. The THC likely remains in the breast milk much longer. And so it can take days for THC to remove itself from the breast milk. And unfortunately, in the study, we were unable to get infant plasma concentration. So we're not sure how much of that THC is then provided to the baby when breastfeeding. But to know that it's there for a long time sends an important signal about informing women about the risk of THC presence in their breast milk. There are some other older studies not done very well at a very long time ago. However, conflicting results about if there was any longer term impact related to motor or mental skills. And at this point, I think most people are saying that it probably does not have an effect long term based on these two studies. We're going to learn a lot more. There are additional studies, as I mentioned. I've given them to you here. I simply won't have time. I want to make sure I get to some of the counseling things that you need, but just know that there are more and more data becoming available every day. So this brings us now to the counseling opportunities and challenges. Going back to our patient case, we remember talking to her. Now maybe we've showed her some of the data. Now the question is, how do we put this into context for her, and what counseling should we give? We also have resources. I know that your county also has resources. I'm all about sharing and being transparent, and it sounds like just based on that intro, you are as well. I've seen some of the information you have available, but these are resources also available to you. This is an advisory group that I participate in with a variety of different healthcare providers, including social workers and some of the legal context related to health concerns and specifically recreational marijuana. We actually look at marijuana use in a variety of different populations, but here I'm sharing with you our findings for pregnancy and breastfeeding. We actually have reviewed literature going back now many years, and we evaluate the evidence. We provide evidence statements saying there's moderate evidence, there's insufficient evidence, there's mixed evidence for any particular finding. We provide information about the article and the details of that article so you know how we came to the conclusion. Here I'm just giving you an example of the prenatal marijuana use on exposed offspring for cognitive and academic findings. Most of these are moderate evidence that there can be potential associations with attention problems, cognitive function. I think IQ may be changing in our next report coming out this year where it's more mixed evidence. But just keep in mind that this is a resource that we're consistently updating. We try to do it every quarter, but we do have to create new reports every 2 years to the state as part of our regulation. And so these are the overall findings for maternal marijuana use during pregnancy and breastfeeding. You can see there's no substantial evidence. So that's one of the difficult parts of this particular population. We really don't have substantial evidence for any outcome related to maternal use of cannabis. We do have some moderate evidence that I just shared with attention problems and reduced cognitive function later in adolescence. And then there's limited evidence in some of the other things that we've talked about, such as small for gestational age, decreased growth. And we have insufficient evidence for SIDS or breastfeeding in SIDS. And then there's a lot of mixed evidence as well, although we're finding that some of these will shift in our 2020 report, which hopefully should be coming out actually later this month or October. We also have some patient and healthcare provider resources that you may find helpful. On the left, this is really the patient pamphlet. We also have a booklet for healthcare providers, and it really just helps to debunk some of the myths. I know in the healthcare provider space, we also talk about mandatory reporting, which becomes a really tough scenario and situation as well. But again, these are resources that are available to you should you choose to use them. Again, I know that your county has worked hard to provide resources as well. I also just want to point out that there are some national guidelines and statements from our major Pregnancy and Lactation Organization, they are very consistent in talking about several things. One is that all women should be asked about their use of cannabis. They should be counseled about concerns regarding potential adverse health consequences. They should be encouraged to discontinue marijuana use, and many of them will discuss things around harm reduction if and when possible. Of course, we want to discourage any marijuana use, but if it's not possible, we want to have them minimize as much as possible. And in light of some insufficient data around breastfeeding, most of our organizations are discouraging marijuana use in this population. The American Academy of Pediatrics follows a similar philosophy where it's important to advise, ask, and counsel regarding marijuana use. They also go on to say that, for women that are identified through using marijuana through universal screening, they should be counseled and receive brief intervention, potentially be referred to treatment. Just understanding that depending upon the state, and in most states, ours is, we still have mandatory reporting. I will just say that our welfare investigations do not often occur with only a marijuana report, but families could be subject to child welfare investigations. And that's something that people should be aware of. And again, marijuana use during breastfeeding is discouraged. The CDC also has created a statement around breastfeeding, just again explaining that harmful chemicals can pass from the mother to the breast milk, and there's potential risk. So we advise this population to avoid products containing CBD in any form while breastfeeding. Of course, that would also apply to THC. I'm not going to show you this video today, but there's a link there if you wanted to see an example counseling session. I have a kind of a role play that I did with one of our students to help you find the words and how do you have this conversation for looking at cannabis use in pregnant patients. It can be difficult, but the take-home messages that I always kind of think about is that there's no known benefits of marijuana use in pregnancy, and there's possible risks. We can advise patients not to use it during pregnancy, and just helping them understand, just like alcohol, there's no known safe amount of marijuana in pregnancy. And we often, almost always, have good evidence-based alternatives for medical conditions that they may be trying to treat, where we know the benefit risk analysis there. And so we really want to try to be using those as much as possible until more information is available. So in conclusion, hopefully you've learned quite a bit. I've presented some helpful information for you. Cannabis can have supraphysiologic effects on the developing endocannabinoid system, and that can create potential changes in fetal growth and development. There's an insufficient evidence to link cannabis use with a specific congenital anomaly, which is good. However, evidence shows associations of cannabis use in pregnancy that can be concerning, both in the short-term outcomes as well as longer-term outcomes. So for that reason, we really want to try to avoid cannabis use during pregnancy and breastfeeding. And I think the only way that we can engage in these conversations in a meaningful way is by us remaining open, person-centered, and really reviewing all medications with pregnant and breastfeeding women as well. And so with that, I want to say thank you. I look forward to getting to the Q&A. We have just over 10 minutes to do so. And again, just appreciate your attention and willingness to share this information with me today. Stop my share, and I am ready for questions.
So, Dr. Borgelt, I have to say that your presentation was so thorough and comprehensive that at this point we don't have any questions. I'd like to remind our audience to please remember to, if you have any questions that you haven't had an opportunity or the chance to place into the chat box, now is the time. So we'll wait a couple of minutes and to see if there are any questions. Go ahead.
I was going to say, one of the questions that I often get that I didn't really touch on, but I think is just an important discussion point. Would love to hear from you participants if they're willing to share. You know, many of our health systems or various areas have certain policies and procedures in place, which mostly tends to keep this hard line of just like, no, 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 no. And I think what happens, at least what we've seen with in particular, our nurses, our lactation consultants and things like that, is that it's difficult for them because they're weighing up the potential of a breastfeeding mom and the importance of breastfeeding and how essential that is for a baby, and maybe an occasional use. And what I call like the Friday night wine night, right? So it might just be once a week they're using. And I think one of the gaps that we have in our literature is really that occasional user. And at least in Colorado, we tend to see a lot of occasional users. Sometimes they are daily users, sometimes they're more than daily users. But I just want to point out that that's an area that I get a lot of questions about, and we really have very little evidence about the occasional use. And it's a really tough spot. And I think especially for these moms, potential moms, what I would often just say is, what else could we do to help give you what you need from that experience? Maybe once a week, they just need to like relax. Okay, well, what else could we do that could help create an environment for you that may make it a little bit more safe? And so it's just finding those kind of alternatives. But I just point that out because it's a question that I get, and I think it's a difficult gap that we don't yet have an answer for.
Gotcha. So this question is from Cherie Walsh. She's wondering about topical CBD oils used during pregnancy. If this type of product can cross the placenta, is her specific question.
Great question, because I want to point out that there's a pretty significant difference between topical and transdermal. And what I mean by that is that with topical, you can have a cream or a lotion which really stays within the skin and does not typically cross the blood barrier or get into a systemic circulation. However, we do have transdermal products that are applied topically, like a patch, for example, and then that will enter the systemic circulation and can get into, it avoids the liver metabolism, but it still can be in the bloodstream. And so that would then pass into other areas of the brain, placenta, breast milk. And so it really depends upon the formulation that's being used. Typically topical, like a cream or a lotion, will not pass through, but transdermal, which is applied topically, can. And so it's a nuance, but it's important nuance because people may have different perceptions of what topical might mean. And sometimes things can get into the systemic circulation and they don't know it.
Gotcha. Looks like we have another question. I can't see who the person is. It's quoting who's posing the question. It says, "Is your data on Reprotox?" Excuse me.
Oh, Reprotox.
Thank you.
Yeah, that's a database that is found in Micromedics. You can look there, but I will just say that most of the data that I shared with you today is not from that. And mostly that's because Reprotox tends to report on FDA approved medications. And while you may be able to find THC because it's found in dronabinol as a product, an FDA approved product, that may or may not actually be the same data that we see with the plant data. And so I really try to differentiate that, but Reprotox can be a valuable resource. Other databases that I've used are Natural Medicine's comprehensive database, which you may have access to depending upon the libraries that you affiliate with. That can be helpful for cannabis, but I have to say that when we're talking about the plant, you really have to kind of dive into the actual studies because a database often doesn't cover plant-based medicine. They cover the FDA-approved medicines.
Gotcha. And we have a question from Dr. Robert Saint, and it reads, can you recommend a best resource for adolescent effects of maternal use of marijuana?
You know, I don't want to be too biased, but I think if you share along with some of the, I don't know, I wasn't able to attend the webinar that you presented here earlier, but if you go to that resource I provided for you, we actually have an entire chapter on adolescence and mental health effects. And so I think I would highly recommend that you go there. And if you go into that website, then what you can do is go into all of the articles that have been evaluated around adolescent effects. With the pregnancy side as well as the adolescent side. And so if you're looking at really maternal use and the adolescents, most of that data is coming from longitudinal studies that started in the 80s and ended in the early 2000s. And so there's some flaws in that data, but there's a series of probably 3 or 4 different longitudinal studies that were published over time that you could find in that database. And if you have specific questions about it or how to access it or have trouble, just email me and I'm happy to provide a better way to get you into that data as well.
Great. And
I'm sorry, I have a question, Dr. Borgelt. I think a lot of folks see Colorado as the knower of all cannabis information. Is there any kind of best practices or tips for what you've learned that you could impart on us as Michiganders considering our now legalized status?
I think there are a couple things I would say, and certainly I would not, we're not the all-knowers yet. We still have a lot to learn, but I will say that there's kind of some key overarching things. What I would say first and foremost is most important to remain open-minded and open to the why of the cannabis use. What we have found is that, yeah, you're going to have your set of recreational users, and that's kind of another context, but most patients, when you're in this type of a situation with pregnancy and lactation, is often a blend of medical and maybe recreational. And it's really remaining open to the why, so we can help explain that benefit risk as best we can and try to look for other alternatives in vulnerable populations. I think it's really about the communication. So I'd say that kind of first and foremost. I think the other thing that I would say is that most of the data, the more recent data, is looking at short-term outcomes. And to be honest, I think if I'm weighing it up with the short-term outcomes and the potential long-term outcomes, I'm actually much more concerned about the long-term outcomes. It can be hard when I'm talking to moms to convince them about an adverse effect that may or may not happen 15 years from now. And I say that as just being honest about the challenging piece of it, but how important it is to be able to find other options for women who may be in this vulnerable place. And I think that's really kind of key message number 2 is what other options might we have that could be a better, safer, more well-known option until we get more information. And I know it's not satisfying, but I really feel like that's the best place. And I have found that the more open and understanding I am in talking with my patients about it, the more amenable they are when they start learning some of the data and the information.
Thank you. Dr. Borgelt, you mentioned earlier, I think when you answered Dr. Sain's question about sharing your email address, how best do you want to do that?
Well, I'll just go ahead and do that now, potentially. I don't know what you're seeing here. Hang on, let me get out of there. There you go. So it's my email is right there at the bottom of the slide, laura.borgelt@cunshoots.edu. It's not easy to spell, so you can just take a note now and then email me. But I'm happy to respond to email questions as well.
Great. And so this last, as we get ready to finish up here, this last question is more of a comment. And I quote from Dr. Sain, "This was a phenomenal review. First time I've heard a full report about the use of marijuana during and following pregnancy. Thank you very much.
You are very welcome, and thank you. I really appreciate it.
I just echo those thoughts by Dr. Sane. And so on behalf of the Washtenaw County Health Department and the Washtenaw County Medical Society, we'd like to thank you for tuning into today's webinar. This concludes our medical marijuana webinar series. We will be adding all of the series recordings to the Health Department website and the Facebook page as well, our Facebook page as well, which is listed in the chat. Have a great rest of your day. And once again, thank you, Dr. Borgelt, for your very comprehensive presentation. It's phenomenal. Thank you so much.
Thank you.
Thank you. Thank you.
Bye, everyone.